see my slides?
Yes.
Okay, so I'm really sorry for all this kerfuffle about internet. The basic thing is the case that Somnath presented presents an interesting aspect of assessment and management of polycystic ovarian syndrome, which is now completely defined by the 2018 guidelines published mainly from Australia. Now, the few things that this patient shows up is, number one is an irregular menstrual cycle. Now, this irregular menstrual cycle, and I find this a little important because I see a lot of young girls getting investigated when they really shouldn't be investigated. And as you can make out from the case that was presented, the patient is 9 years post-menarche, and that is very important. I'd like you to keep a watch on that. So in the first year post-menarche, between 2 years and 21 days or greater than 45 days would be defined as irregular menstrual cycle. And if it's greater than 3 years post-menarche to perimenopause, less than 21 or greater than 35 days would be defined as an irregular period, or somebody having less than 8 cycles per year. And for more than 1 year post-menarche, you would define it as irregular only if it's more than 90 days for one cycle, and primary amenorrhea by age 15 or greater than 3 years post-thalaki is what we would define as an irregular menstrual cycle. So the criteria for describing irregular menstrual cycles are absolutely clear, and these need to be followed properly. This is published in 2018 in Human Reproduction. I have given the DOI for this because I think it is very important for all clinicians dealing with PCOS to stick, because otherwise you will end up investigating people who do not investigation. In addition to that, what other information do you want? I thought in the case you need a family history. Is very common in patients with a family history of diabetes, particularly fathers, women, the girls develop polycystic ovarian syndrome. A blood pressure should be measured because of not only the risk of hypertension in patients with PCOS, but also because blood pressure would give you kind of idea of many differentials that PCOS has. The presence or absence of acne and frontal balding should be noted. There are various criteria. The frontal balding is looked at by the Ludwig's criteria. This needs to be assessed properly. We need to make sure that there is no purple striae to exclude Cushing's. We also need to check on the voice and clitoromegaly so that we can exclude any kind of androgenic disease. Of polycystic ovarian syndrome, and this is a very interesting picture of actosis with skin tags, which Dr. Anirvan has shown in that in the is hyperandrogenism. 30% in alopecia and seborrhea are also present in a large number of people. Anovulation in the form of oligomenorrhea is present again in about 75% of patients. And ultrasound of ovaries, as you can see, it is quite heterogeneous. Between 80 and 100% show polycystic ovarian syndrome. In addition, there are certain associated conditions like obesity, which is seen in 40% of people. Insulin resistance is common, and type 2 diabetes is common. All the features of the metabolic syndrome, metabolic syndrome might association with mood disorders. Essentially, polycystic ovarian syndrome is a cross point of hyperandrogenism and anovulation, and there are 3 diagnostic criteria: the NICHD, the Rotterdam criteria, and the Androgen Excess Society criteria. All of them are more or less the same as far as hyperandrogenism and chronic anovulation is concerned. In addition, some criteria need to have demonstration of PCO by ultrasound. And all this has to be taken into account, excluding hyperprolactinemia, non-classic CAH, thyroid dysfunction, androgen secreting syndrome, which are quite apparent, I think, most of the time. So the investigations to be done include a diabetes and lipid screen. This is very important because of the connection with metabolic syndrome. We check for androgens with testosterone level. We check FSH and LH if the periods are irregular. If the periods are regular, we take TSH and prolactin to make sure we exclude the differentials. I usually, if I suspect that there is any kind of phenotype of Cushing's, I usually do an overnight dexamethasone suppression test to exclude Cushing's. And of course, 17-hydroxyprogesterone levels are elevated in non-classic CAH, and of course, the ultrasound ovaries done by a very highly trained professional. But one thing of note, as I repeat my slide, is that there is no measurement of serum insulin in any of the criteria. I think a lot of gynecologists particularly are guilty of measuring serum insulin, and I think this should really put a stop to, because measurement of serum insulin adds nothing to the diagnosis of diabetes. It is not considered a diagnostic criteria, and this is because patients are overweight or obese, and most of them will have insulin resistance of PCOS, but should just by their body weight. And also the clinical quantification of IR is not accurate, so it need not be done. What we need to exclude are other conditions like hyperprolactinemia, etc. But most importantly, I think we need to exclude 21-hydroxylase deficiency. This is what happens. 17-hydroxyprogesterone goes up, which stimulates secretion of adrenal androgens. And usually they present with same features of CAH. And if they their main problem is getting pregnant, and a lot of them get pregnant without glucocorticoids, but they have a high risk of developing miscarriage. So are put on hydrocortisone treatment, which would there was no evidence of an elevated 17-OHP. If 17-OHP is borderline, we do a synactin test. Unfortunately, it's very difficult to do because synactin is not available here anymore. So we looked at the patient now. We find the prolactin, cortisol, thyroid function test, urine pregnancy test, as well as 17-hydroxyprogesterone are all normal. So we have excluded other things. We do not have a very high testosterone. Neither do we have a very low SHBG. So, you can kind of exclude androgen secreting tumor in which testosterone levels are very high, but and DHEAS. So testosterone measurement is very difficult. Free testosterone is probably the best to do. Assay is very, so all the world, there is a kind of to be done, and the way of diagnosis is probably the free androgen, which is calculated by 100 total testosterone divided by HB. And if you cannot do that, you do total testosterone or a DHEAS and androstenedione down. So these are the ways you can demonstrate hypoandrogenism. In most cases, you will find that hyperandrogenism is very demonstrated by clinical features. Ultrasound of ovaries is also to be done by trained old classifications, 12 or more follicles, 2 to 9 millimeters, and an increased ovarian volume. This is again changed a little bit. So this is now ovarian cysts of more than 20 and an ovarian volume of greater than 10. It should be done in patients only with a menstrual age of more than 8 years. If you remember this patient, I will show you the patient has a menstrual age of 9 years, so you can do it. The transvaginal approach is the best. It's particularly in sexually active women. This provides the best diagnostic thing. In the absence of it, you should go for a transabdominal, which shows ovarian volume of more than 10 milliliters. So she's had menarche at 14 and she's now 23. So she's more than 8 years. So she's got reason to be investigated with an ultrasound. There's a popularity of the anti-Mullerian hormone. And again, this is not used as the alternative. these days there's a lot of diagnostic and research going on in AMH, and I think the day is not very far when AMH will detection of PCOS. And in fact, we had, when we did the Indian Fertility Society guidelines, we had taken cognizance of this and said that anti-Mullerian hormone levels should not be used for the diagnosis, either in adults or adolescent women. So this is how you diagnose. So my answer to the question that was proposed would be to do an ultrasound of the ovaries with a trained operator. And the take home from this talk is that we need to take a proper history, examine the patient, demonstrate anovulation and hyperandrogenism. The investigation should be sensible. There is a tendency to do a lot of things, and we should move away from it, and we should exclude other conditions. For creating a bit of a scene with the slides. Any questions?
Nice.